I'd like to introduce Dr. Jackie Stern. Dr. Stern was raised and schooled in sunny Southern California, UCLA, and then UC San Diego for medical school. Discovered beautiful Colorado in the 1980s, where she enjoyed her residency and practice in family medicine until 2018, when she retired. Dr. Stern was in private practice for years before joining the faculty at CU in family medicine, and then went on to be part of a house call practice that specialized in care of the homebound. This included palliative and hospice home care, as well as care of people living in assisted living and memory care dwellings of all types, including Kavod, where she developed a great fondness for the great people who work and live in these towers. Please welcome Dr. Jackie Stern.
For a small group, but I'm going to stand here and and I'm sure everybody can hear me. So I'm going to start really by giving you a summary of my thoughts and learnings around the excessive use of medications in an aging population and what were benefits becoming harms as people age, potentially, depending on the medications, depending on the coexisting conditions, depending on many, many factors. But with Rabbi Geller's thoughtful start and wonderful talk that we just listened to, this is much more concrete. I will still give you homework to leave here with, so you can think and talk about your goals and desires with your loved ones, with your doctors, with others, as you reconsider potentially what you may already be taking, or if you're caregiving or living with others who are on numerous medicines and you're wondering, is this really helping their quality of life? Is this really consistent with their goals of living? Or is it actually shortening their quality of life or impairing the quality of their day-to-day existence? So in medical circles, what I'm talking about is called polypharmacy. Not really about numerous pharmacies, but about numerous medications that are often consumed by people, especially as people age. The numbers and varieties escalate madly. We've all heard that we're in a healthcare meltdown in this country. We hear dramatic words like catastrophe in reference to what's happening in the healthcare system, and it most certainly applies in the largest way to our elders and the care they may receive. Blame goes in many directions on the complex healthcare system or non-system, as the case may be, on pharma companies and advertising and drivers of medication sales that have little to do with the good care and health of the people taking them at times, on disparities in healthcare, and on non-communicating electronic health records, where you may find yourself or your loved one in the emergency room and the med list that gets pulled up is from the last hospitalization 2 years ago with the hip replacement, and it was wrong then, and it's really wrong now, and nothing gets updated because the electronic records don't communicate with each other between your doctor's office, which doctor, by the way, there might be 6 of them, depending on how many specialists are involved. So it's quite an unbelievable mess. This, despite the fact that physicians have sworn at graduation to do no harm, when it comes to the good care of an aging population, polypharmacy, or the use of numerous medicines, has got to be essentially top of the list. It isn't number one, though. Number one is really, what are the goals? What are the goals of the individual? If you're here because you're wondering about your own med lists and your own questions, or whether it's around someone you love or care for, that is really the number one question. I propose that we take a look at one problem at a time as we look at the care of ourselves, our loved ones, our parents, our patients, in order to effect systematic change in their care. As a physician who's cared for elders, I encourage you and those you love to advocate for themselves, to express your opinions, to have these hard conversations, as difficult as they may be, so that those you know and care about are all on the same page and conflicts don't happen in the midst of a crisis. Decisions don't get made well when people are in an emergency room with someone acutely in trouble. So the hard conversations really must happen in advance of that if these ideas can be carried forward. Let's imagine a theoretical patient. I'll call her Shirley, after my own mother-in-law, late mother-in-law. The cardiologist had one list, built years ago when they last saw her while they were treating her high blood pressure and her hyperlipidemia, and, oh, by the way, the AFib, which everyone always seemed to forget to mention, even though she was taking warfarin. The family doc had a lengthy list that also included bellyache medicine, constipation drugs, headache prevention medication that was started years ago and still on the list. Then there's the daughter's list, which also included multivitamins, the omega-3s that she had read about, and the eye doctor drops, which actually can affect the heart and the blood pressure, and nobody ever thinks of those as medicine. And the doc who saw her in the ER when she got dizzy a few months ago and prescribed yet another medication when she had a UTI. Let's not forget, Shirley has an opinion of her own, and she just won't swallow all those pills, so she has a different list, and she believes that's the most important list, and that's an essential ingredient to sorting out where are we and what kind of a mess are we now in. So how do we help ourselves to live safely and with the respect we deserve to the details of medication management? How many meds is the typical 80-year-old on who is admitted into an independent living or an assisted living? On average, when the studies that have been done show that the typical 80-year-old is on up to 10 prescription medications. That doesn't include the over-the-counter supplements and vitamins and ibuprofen and eye drops and all the other products that you can readily get over the counter that can all interact with the other medicines and that often aren't necessary and have massive potential for side effects. We all have likely had the experience of opening our parents' or our loved ones' drug cabinet and being horrified and just closing it because it's too much to even fathom. How do I get through this? And mom and dad don't want to throw away those old pills. And oh, by the way, the pharmacies are automatically refilling everything every month. So they have a stockpile of medications that is valuable, dangerous, and really almost an unbreakable cycle. I don't know how many times any of you have tried stopping Walgreens from sending those refills that you no longer need. It's nearly impossible at times. And so there are just more than a few places for problems to evolve when it comes to too many medicines in the medicine cabinet. I propose that medication reevaluation and simplification is critical to managing the chaos. Whether you're the patient, the daughter, the nurse, the son, the doc, whoever, it needs to be repeated not just once, but every single visit. Many providers ask that you bring your medications and your lists, multiple lists, to doctor's visits, and that is an attempt at some level to do a medication reconciliation. But it takes time, and most doctors' offices are not set up with the time or the skills to have an honest management around these issues. So it takes, excuse me, I touched something. It takes a lot of attention to those details for that to be addressed. Starting with, if anybody has a notepad and they're taking notes like you were with Dr. Geller's, sorry, I'm going to go back a bit because I touched that by accident. Sorry. I at the front? Yeah, no, I'm at the end. Okay. Sorry. The computer has a mind of its own at this moment. Okay. So, questions to note for yourselves as you think about this big picture and how to try to whittle it down to a simple, systematic approach. Collect the lists from each person involved. Look at what the assisted living has. Look at what you have. Look at what mom has. Look at what's in the drug cabinet and in the nightstand to know what is really being used on a day-to-day basis or a periodic basis by you or by your loved ones. It's important to clarify why each medicine was prescribed, by whom it was prescribed, when it was started, and for what, and for how long was it intended to be taken. One of the questions to associate with all of these questions is, are there any drug interactions? Those are questions for your doctors. Could my warfarin that I've been taking for years for my AFib, is it time to reconsider that? Is there a newer product on the market or a different product that might be safer? Or for that matter, is this a really silly medicine to be taking when I actually fall down every month because I'm unstable and I have these horrible bruises and my body isn't metabolizing this drug like it used to? And so what once was a stable, consistent dose is now all over the place. Those things need to be revisited regularly. Is the benefit of this medicine worth the risk? We know what the goals are. We need to know what the goals are for each person. Do they want to be medicated anymore? And what is their medication doing in terms of adding or taking away from their quality of life? Is this medicine making them dizzy? Is it making them constipated? Are they taking 3 other medicines to make up for the side effect of medicine number 1? So you layer on additional problems because you started out with one medicine that simply wasn't suited to their body or their constitution. Can it be stopped easily, or does it need to be done slowly and methodically with caution? These aren't things that most individuals are comfortable or appropriately making alone. That's where a healthcare team comes into place so that things are done, in my opinion, one at a time, not quickly, so that over the course of months, you take someone down from maybe 15 medicines down to 5. That is not an unusual outcome when it's addressed in a methodical way, and people, by and large, and I have done this for years, feel unbelievably better on much less medicine. Because of the side effect profiles of so many of them. Other questions to be on the list as you ask yourself, why is this person on this? Is the problem this medicine was given for now resolved? Is our theoretical Shirley, is she 50 pounds lighter than she was 5 years ago when she was prescribed those diabetes medications, and now she doesn't need those medicines anymore, or she needs much less of them, or her kidneys aren't as strong as they used to be, and everybody's following her kidney function, and oh, by the way, she needs only half the old dose to get the same effect because the medication is circulating in her system much longer than it used to. Are those cholesterol drugs impairing her ability to walk comfortably because her muscles are all hurting? Maybe those aren't the right medicines anymore. Maybe they don't provide the benefit that they did when she was 60 or 70, and here she is 90 and is still on a cholesterol-lowering medicine. Does that even make any sense? Is that multivitamin giving her an upset stomach? And what about the omeprazole that got started in the emergency room a few years ago because of the tummy ache? Is it, in fact, making her more at risk of having pneumonia? Are there side effects for what we think of as very innocuous medicines that don't get talked about widely because they're over the counter and they're advertised in the middle of the news channel and everything else that we watch all day? And what about that warfarin that I mentioned earlier? Does she really want to be poked anymore for INR measurement, or are there other alternatives or simpler alternatives, or no medicine potentially that is even necessary anymore? Maybe she's like, I'm done with medicine. If I had a stroke, maybe that would be a blessing. People get to different points in their lives where they're like, why are we doing this? What is the quality of my life now? What do I want? And that deserves to be listened to. So there's no one who should ever be saying you must take this medicine if it isn't in the if the person cannot be a part of that conversation or hasn't deliberately expressed that in some way at some point. I ask you to consider who decides. What are the goals for that individual? I ask you to consider all of these questions that we've talked about as you care for yourself, as you care for Shirley. I'm going to take you through a series of slides that will help emphasize some of what I've just talked about, and then I can also take some questions, and we'll see if this helps move you forward towards having a meaningful conversation with multiple doctors, primary care, whoever's involved, or just family to begin with around, whoever you consider family or your closest people in your lives that keep an eye on you so they know, what do you want? Where are your med lists? Is it posted with the most form on the refrigerator? If you don't know what that is, that's a different conversation. But those things go hand in hand. Because in particular, because of that ER mess that happens almost every time somebody goes into an emergency room. They've got the wrong med list in place. All right, so we talked about the meaning of polypharmacy, and that scene is not unusual at all, as you probably all know. We talked about how many medicines it takes to make it polypharmacy. The actual definition is 5 or more medications, prescription medications. And when you exceed that number, it's very clear on numerous studies that the risk of fall, disability, death are much increased. 5 or more prescription medicines start to really increase the odds of trouble. So I know that I'm on 3 prescription ones and 2 that are non-prescription that are regular, and I'm very healthy, and I'm not 80, but even those things are mounting over time. We talked about, do medications cause sickness? Should they be avoided? By no means am I advocating for dropping all medicines all at once or recommending that medicines are a bad idea. Medicines are, in my opinion, very, very helpful to living a longer, healthier, more active life for many, many people. And I'm as big a questioner around medicine as any, and I do take mine because they change my outlook for different problems. Again, just studies that have happened over the years, the numbers of interactions and different levels of chronic disease that overlap because people don't have just one system going haywire. They have different things. We have diabetes and high blood pressure and maybe a blocked coronary artery that might be in the background that people are paying attention to, or a neurologic impairment or a gait disability. So it's a balance always between risks and benefits. I have basically already talked about our theoretical Shirley. This was a case study created by a friend of mine who did this slide around a very common situation. A 77-year-old woman who had diabetes, high blood pressure, heart failure, kidney disease, high cholesterol, heartburn, knee arthritis, neuropathy in her feet, glaucoma, depression, and insomnia. That sounds like a lot. It's actually quite common that people have numerous problems that they're dealing with. And if you look at what that medication list looks like, it's impressive. medications for diabetes, medication for blood pressure control, medication for cholesterol and depression and anxiety and sleep and pain, eye drops for glaucoma. Those are very, very commonly used everyday medicines for a lot of people. Not only is it a lot of medicines, it's a lot of medicines to manage in terms of taking them correctly, consistently, because that has an impact on how well they work. And if meds are taken here and there, or because I like to take that one on Tuesday, and my patients would show up with their bottle full of all the medicines in one bottle, and it's like I take the pink one in the morning, and and I'm supposed to know which medicine is which. I'm like, oh my goodness, how do we do that? How do you deal with this? So it's a very complicated problem, and one that requires a good deal of organized attention. In that particular list, that patient was taking a whole bunch of things that potentially could be enormously damaging over time. So the metformin that worked for her nicely, great drug for type 2 diabetes, but when your kidneys aren't working well anymore, big problem. And is that being monitored, and did anybody bother adjusting the dose? These different conditions and different kinds of medication combinations can cause confusion. They can cause a much greater risk of falls, a much greater risk of not being able to get out of bed safely, to get up to the bathroom at night. This is just a silly slide about somebody we all knew and loved once, Mick Jagger, before and after. This slide is intended to show some of the changes that happen as the body ages. When the body ages, there's an increase in the body fat, a decrease in muscle. We know that. That's part of why weight-bearing exercise is so important. It also affects how medications are metabolized, as do these other details, the body water and plasma volumes that decrease. I'm not going to get into any of that. Hospitalized patients, people who are hospitalized are at much greater risk of having been on too many medications compared to people who aren't as likely to end up in the hospital. So the more medicines people are on, the more likely they are to land in the hospital. Granted, they have more illnesses, and so that changes how you look at these numbers. Part of what also happens is many disorders, common disorders, the standard of care are 2 or 3 medicines, and when you add 2 or 3 different major disorders, whether it's heart disease or high blood pressure or diabetes, and each of them has 2 or 3 standard first-line drugs, you've just multiplied it out and you're up to 10 meds in no time flat. And it makes it complicated. And so when you're seeing an endocrinologist on one side and a cardiologist on the other side, and they're doing a really good job at their narrow focus, it doesn't work safely if somebody isn't paying attention to the big picture. And most of the specialists do know how to modify things so they can take into account the fact that, oh, we do need to be seeing what's going on with your heart before we add another diabetes medicine. But unfortunately, that doesn't always happen. So it's up to the individual and their care team to make sure they're advocating for self or for others. To make sure that mistakes are not happening. This is just a riff on the advertising for prescription drugs. Oh, sure. It says, why are they advertising prescription drugs? So you can tell your doctor what you need. Too bad he wasted all that money on medical school. We all see that. We see drugs that you simply would never, ever have access to that are prescribed. Talk to your doctor about Stelara, or talk to your doctor about Humira, or all, drugs that are really fabulous for the right person at the right time. But why? This has all become a big pharma game that is really making people feel like, well, I have psoriasis and nobody ever talked to me about being on this $1,000 a month drug, because in fact food is a really important place to spend money, and medicine not so much necessarily in some circumstances. And when people forego their basic needs, they're literally can't afford their rent because their diabetes medicine is through the roof, the whole thing is craziness, especially with the added complexity of medicines that are being advertised on television that have no business being there, in my opinion. So that's really the bulk of what I was going to talk about today. I'm really happy to take questions. I don't think there's more I need to do that's on the slideshow that will be of interest. Yes? Mm-hmm. Well, I will also, if you look at the fine print on some of these, this is some old information, and I don't know that I've seen anything that's really current in terms of the numbers. I think it's higher. I think it's higher. I also think the amount of unstudied product that is available to people through over-the-counter access and homeopathic treatments is incredible, what is available to people. And some of those things have very strong medicinal impacts, and many are not studied. And so that's another piece. So I actually think it is higher when you really drill down. And in different populations, it is wildly out of control. So yeah, no, that is interesting. I did scroll down to one potential medication interaction problems is also an ongoing problem. There is something called Beers List, BEERS. It was most recently updated in 2019, and that's something that any knowledgeable prescribing doc ought to be familiar with. And patients can certainly look these things up on the internet as to which medicines that my mom's on or that my sister's on are on the Beers List, and should we be questioning those? The Beers List are things that are potentially troublesome when taken in combination or incorrectly. It's not that they're useless medicines, they're wonderful medicines in many cases, but they just can be dangerous when they're interacting poorly. Yeah, hi.
What does PIMS stand for?
PIMS is potentially inappropriate medications. And so it goes along with the Beers List and with other listings of risks to patients taken incorrectly. Thank you.
And I'm just curious, I've seen this situation numerous times where people have multiple medications from multiple doctors and nobody seems to have the comprehensive list.
That's right.
And my brain says, well, I should go to, I don't know, my primary physician and say, could you please look at all these lists and make sure that this all makes sense or help me figure out. Is that what you recommend, or what would you recommend?
I totally recommend that. I mean, that to me was my job. And it is a very complicated puzzle and a really essential piece of managing it. So primary care is, we are the heart of, in theory, of knowing what's going on. But again, because of the lack of communication between primary care and the specialists, because the electronic medical record systems do not integrate unless you're at Kaiser or you get all your care. Kaiser is great because everybody sees the same stuff. And they actually send out alerts if a prescription gets made that doesn't match the other stuff that was on the list. Whereas when I was at Rose, I couldn't see what National Jewish was doing with my patient. And when I'm watching, my husband's getting a bunch of specialty stuff done at National Jewish, they're doing a great job, but they don't have primary care there. So his primary care doc, who's down south, is we're just sending him copies and copies, paper copies of everything because he can't get into the system. So yes, primary care is really perfect for that role, and but it requires regular reassessment. Yeah.
I know it's probably, it's what I'm going to ask is probably a topic for its own talk, as opposed to polypharmacy, but is there anything you want to say about pain management and opioids?
Oh, it's huge, and so it is. It's absolutely its own talk, and the theoretical patient that we had that med list was on NARCs for her chronic osteoarthritis, and I won't say that there isn't a place for that at all. There absolutely is a place for careful and appropriate pain management. It is becoming so difficult now for physicians to prescribe continuing narcotic use, even in appropriate patients, because there are so many limits being set on the counts of pills that are being allowed to be dispensed, even in people who have never had any addiction or any consequences from the doses they're on. But it's all part of that picture, and especially when it comes to falls and confusion, if you take narcotics and you mix them with, say, a little Benadryl, because somebody's used to taking their Tylenol PM is Benadryl at night. Benadryl is a horrible medicine for a lot of elders. It makes them fall down. It makes them have amnesia. It's just it's an archaic medicine that's been approved forever because it's been around for 100 years. And so it doesn't require any testing or FDA screening. If it came out now, nobody would approve. Simple old Benadryl. Great drug for the right problems, but not for a daily use in people who are at risk of falling down or confusion. Confusion is a total disaster because, when your loved one keeps all sorts of meds in their bedside drawer for what they take every night, and they don't remember if they took it, so they take it again, and you do a pill count or you do whatever you do to assess where are we with how you're taking your meds, it's horrifying. They're like, oh, wow, you took all of those in the last 3 days. They were supposed to last for 10. And that actually happens all the time. And it's not that everything has to be a locked box, but depending on the cognitive ability of the person who might be needing medication regularly, there are some safety systems that are in place so that everything can be dispensed, even through a pill box that has an automatic dispenser that can be set up that doesn't allow someone to get things too often. Does that help a little bit? But yeah, narcotics and benzos, they're a huge issue, and they're not, they can't go away. And there's a role for them. We don't have often better things. There are some alternative pain medicines that can be helpful, but they're not always a solution. Anything else?
Well, I so agree with having polypharmacy. We have to be so suspect for our own self and be our own advocates and apply wisdom to what we're taking. However, does the same thing apply to vitamins?
Yes.
Because, I don't take medication, but I do take my vitamins. So, and I know that there's no FDA really that watches that too carefully. What do you think about that aspect of what we put into our system?
So vitamins are medicines. There's no doubt that vitamins are medicines. And some vitamins, A, D, E, and K, deposit in fat. So you don't just pee them out. It's not like if you take too much vitamin C, you might get a bellyache because it's ascorbic acid. So it's highly acidic, highly irritating. And if you take too much of it, your body gets rid of it and you just have a lot of vitamin C in your urine. But A, D, and E, and K can cause trouble because they deposit in fat and in liver. And so people with declining liver function and declining kidney function can get into trouble with these things. So vitamins are absolutely necessary in terms of putting them on med lists and then evaluating, are they even of any use? Most studies on vitamin use for prevention of cancer, for bone health, there's certainly a lot of discussion around calcium and vitamin D specifically in bone health. They are absorbed okay, but nothing like food with calcium and vitamin D. In the absence of people nutritionally getting what they should get from food, which is where I'd rather they spend the money than on vitamins that they may or may not even absorb, and which aren't generally regulated in any major way, so you don't really know what you're getting. There are a bunch of the American pharmacy vitamin makers have some sort of a label that does say they are made in settings that are regulated, so you actually are getting 250 milligrams of calcium or magnesium or whatever you're taking. But I can't say a blanket statement that I think they're good or bad. And that's, again, a very appropriate discussion with your primary care or your specialists as to whether they think that's a useful risk.
Doctor, I have a question. What about Tylenol and Advil and Aleve for arthritis, which I have, and I take Tylenol maybe every 4 hours if I feel it's really acting up. Is that, I don't think it's helping. Is that worth anything, or is that real harmful?
They're really important medicines. So Tylenol, if you're heading to more than 2 grams a day, 2,000 milligrams, and depending on whether you have a perfectly functioning liver or not, can be a problem. It can be very helpful for a lot of people without the more serious potential problems that are present with Aleve and ibuprofen. Those are also really helpful, but enormous risk of bleeding in the gut and other side effects, including constipation, on top of the gut distress, and very tough on the kidneys. So heart failure increases a lot. Many people notice that as soon as they take ibuprofen or Aleve, that group, nonsteroidal anti-inflammatories, that as they age, that they start having swelling. And that's their ibuprofen and Aleve that are making their ankles swell because their heart function is decreasing and it's just not metabolized as well. So to me, there's a place for all of them in great moderation and knowing that depending on where your body's at in terms of tolerating them, they can potentially be a big problem. Does that answer that? Yeah, they are very real medicines. Again, things that, again, Tylenol's been around forever. Nobody would ever put it through the big FDA review at this point. But there's good use of it, too. Yeah.
Last question.
That's fine.
I take the gel that you put on pain.
Voltaren? Diclofenac?
Yeah, right, I take it, the prescription one. And would using too much of that, I put it on my leg, I put it on my back.
Go for it.
Anywhere, everywhere?
It is really almost impossible to hurt yourself with that.
Really?
If that works for you, it is a wonderful approach to local pain.
That is instead of Advil, Motrin, those.
Right.
Celebrex is no good.
Celebrex falls in the other category. It's a good, strong anti-inflammatory, but has potential for great impact.
Did I hear you say that Tylenol could, too much see, I take Tylenol in the night to help me go to sleep, and I try to put that stuff on.
That sounds like a great combination.
It is? So
it's probably great.
Should I take no more than 500, one pill, 500 or 200?
It's very hard for me to speak directly to your specifics because I don't know any of the rest of your medical picture and other medicines, but generally no one is going to hurt themselves with 500 milligrams of Tylenol at night.
Oh, every night?
Every night.
Is there a naturopathic doctor or an organization of doctors where we could find somebody who knows all about supplements? I know they're not approved by the FDA.
I can't tell you I have that for you. I'm sure there is, but I don't know what it is. I know that the FDA has a division that has all the homeopathic and supplemental herbs and vitamins, all their evaluations, but I don't know off the top of my head what that link is.
Dr. Stern, thank you so much. This has been really helpful.